Fine.
All right, so it looks like it's just now 10 o'clock, so I guess we'll get started. And
Yes.
just to say welcome everyone to what is hopefully the first of a series of case presentations. I am Gerry Gianoli. I'm one of your hosts. I am joined by my two other co-hosts, Mohamed Hamid and Eugen Ionescu, who are two good friends and colleagues and people who I respect immensely in the field of audio-vestibular medicine. I look to them as some of the international experts, so I'm interested in their comments and thoughts on these discussions. I'm going to take the honors of doing the first case presentation, and then we're going to rotate the cases after that. Next month, as you can see from my slide here, is Dr. Hamid is going to do a case on May 2nd, which is the first Friday of that, and then Dr. Ionescu is going to do the one following that.
I'm sorry, Jerry, is your
Yes.
screen, yeah,
Are
I'm
you, do
seeing,
y'all not see my screen?
no, yes, you switched it, you just flashed it and went away.
Okay. Does anybody not see the slide? I have a slide up right now.
Yeah, it's okay for me.
Okay, good. All right. So that's just to let y'all know the next event is going to be May 2nd, same time. We're hoping to make this a monthly conference, and I'd ask everybody to keep their monitors muted until you talk, just to prevent any background noise. So this is the outline I have for the discussion. I'm going to present the history and physical exam, and then I'm going to ask Mohamed and Eugene to give us a differential diagnosis as to what they would expect given if someone like this showed up in their office. Then I'm going to present the vestibular testing, and we'll have another discussion kind of narrowing down the differential diagnosis, and then imaging, and I'm going to have my good colleague, Dr. Bradley Shore, who's a neuroradiologist I work closely with, who will present the imaging for the case. And then we'll have a more free-ranging discussion, and I'll ask anybody who's interested to comment and bring in their thoughts. And then lastly, we're going to talk a little bit about the case for next month. So the case I presented here is a 41-year-old male who has a history of 12 years of dizziness after a concussion from boxing. And this is what I advertised, but in truthfulness, this isn't exactly the story. He was actually involved in Thai boxing, which I was not familiar with. So I thought it would be worthwhile just to let everybody see a little bit about what is Thai boxing.
And now, in the main event, we have three-minute rounds of a 140-pound Muay Thai super fight.
Down! Up, down! 1, 2, 3, 4, 5.
All right, so I added that little segment just to give people an idea of what exactly was the trauma our patient went through. He was unfortunately not one of the guys standing at the end of the boxing match, but presumably, from my understanding, he had a mild traumatic brain injury or concussion, very short episode of loss of consciousness, and no serious prolonged symptoms afterwards, other than the dizziness. He was referred to me by a neurooptometrist for the dizziness and concerns of a possible third mobile window disorder. The reason the neurooptometrist was seeing the patient was due to diplopia and was diagnosed with a left lateral rectus palsy and a minor right rectus palsy. He was treated with prism lenses. So when he came to see me, the story he gave me is that he was 2 to 3 months after the concussion he got from the Muay Thai. He was drinking a cup of coffee, and after he finished the cup of coffee, he had an episode of vertigo. And from that moment on, he's had constant disequilibrium that has progressively gotten worse. He reported only 10 episodes of spinning vertigo lasting seconds, and each one of those resolved with canalith repositioning. Triggers or things that would exacerbate his disequilibrium were sound, coughing, sneezing, fatigue, and after meals. Further, he was light sensitive and had the diplopia, as we mentioned. His auditory symptoms were not his main complaints, but these are ones I elicited from him. He felt he had some muffled hearing in the left ear, constant high-pitched tinnitus in the left ear, and left oral fullness. His physical exam, he was physically fit, mesomorphic build, 6 foot 4.5 inches, 240 pounds, BMI of 28.9. He was in good shape. Imagine he kind of looked like what you would think an actor in an action adventure movie would look like. So someone in good shape. His ENT exam was normal, including the microscopic otoscopy. Gait and Romberg testing were normal. Akuta stepping test lateralized to the left side. Again, kind of going with that left theme we're seeing here. His infrared video goggles exam revealed no spontaneous nystagmus, and the head shake test did not elicit any nystagmus. Prior treatment and evaluations. The interesting thing is he figured out on his own that noise-canceling headphones would improve his disequilibrium. He found it was the most successful treatment he had undergone. He had been using them for 9 to 10 years and noticed that he needed to use them on both sides. He couldn't just use them on one side to help his disequilibrium. The prism lenses for his diplopia gave him limited benefit, and hence why he was seeking further treatment. He had multiple extensive prior evaluation, including neurology multiple times, ophthalmology multiple times, otology and neurology multiple times, even cardiology and cervical muscle injections, all essentially to no avail. His prior audio-vestibular evaluations, he told me were normal. I did not see the results, but he was told they were normal. He had an MRI scan shortly after the onset of his disequilibrium 12 years prior, and he was told it was normal. He had a history of migraines with aura. He has not had any prior vestibular rehab therapy and was told that this was likely a psychosomatic problem and sent for psychotherapy for 3 years. And obviously this didn't help either. So at this point, I would like to kind of throw up there for Eugen and Mohamed to kind of give me what would you say is your differential diagnosis for a patient showing up with this presentation? Mohamed, you want to go first?
Okay, I have a question. When was his last vertigo spell before you examined him in the office?
Well, I will tell you, that's an interesting thing because I provoked it in the office according to something he said that didn't necessarily cause vertigo, but apparently the last true vertigo spell had been at least a year or so before.
And you haven't seen his vestibular testing. Did you ask him what happened when he had his caloric testing, for example?
I did not. But apparently it was quite a while prior that I'm not sure he would have remembered.
Right. Well, it's the diagnosis is very interesting here because it would include an element of post-traumatic recurrent vertigo, if that was documented, especially if it responded to CRP. Second, he has migraine with aura, so that would be something that should be considered as well, and apparently it has not been treated. Now, I'm also wondering about his eye exam and the left lateral rectus. Was that after the match? In other words, his exam before everything was pretty good, normal, right?
Correct. The lateral rectus palsy was after the concussion, not
After the
before.
result
And
of the
from the patient's description, it was kind of a slowly progressive problem with, and diplopia might be a little bit of an overstatement. It's not exactly diplopia, but
yeah.
the images would be just a little bit off. So kind of a mild diplopia, if you would. And apparently, if he tried real hard, he can correct it, but it was having more and more trouble compensating for it.
And his audiogram, I'm sure you've looked at that, or you didn't.
I've got the audiogram in the next slide.
Okay, fine. So this would be my differential diagnosis for now.
Okay. And Eugene, do you have anything to add for differential diagnosis?
First, I would like to know what was the lapse of time between the lateral palsy and the concussion as the left lateral oculomotor
So we
palsy.
don't know. Yeah, we don't know exactly, but we do know he did not really appreciate any symptoms from the concussion until 2 to 3 months afterwards. And then the lateral palsy apparently developed slowly over time and progressively has gotten worse.
And the symptoms of it was a common migraine, or it was a visual migraine, or vestibular migraine?
No,
What kind of migraine?
yes, my understanding, it was not a vestibular migraine. He had not had any vertigo or dizziness prior to the concussion, although he had migraine with aura prior to the concussion, and it would just be a headache, no vestibular symptoms at all.
Okay, and the last, what was there was a trigger to when the patient develops vertigo, or was spontaneous vertigo? That were, and you said that he got some manipulation for posterior canal. There was, so we can say that the patient exhibits some positional vertigo.
Yes, yes, Eugene. My understanding from the history was he only reported 10 episodes of true spinning vertigo. All of them were short-lived, less than 30 seconds, and they were all resolved with canalith repositioning.
Okay.
You know, Jerry, I want to, obviously that was not his first match, right?
Correct. I would think so. I'd hope so.
I'm
He'd
just
been in it
assuming
for-
that he
he'd
had
been in
had,
boxing for about 5 years by that point.
okay, and what's also interesting that he had multiple, shall we say, ENT, neuro-ophthalmology, neurotology. I'm not going to hold the ENT and neuro-ophthalmology to the letter of the law here, but the neurotologist, did they document any basically vestibular findings on that exam? Or maybe they didn't do it.
Yeah, I don't know the answer to that because I never got any old records of this. I mean, I know he had vestibular testing, but I did not get any records of it. And I'm with you because I've had patients who have said, oh, they said everything was normal. And then when I get the records and I look at it, it's
Yes.
not exactly normal. And it may have just been that was the patient's impression of it. But that's all the information I had at the time.
And then one of the doctors, the guest doctor, Sausan Abu Zaid, made a question about, he was kind of wearing the headphones. So be sound sensitive, and that could be, I think, due to migraine or something intrinsic in the ears.
I'm
Yes,
sorry.
might be.
Mo?
Okay.
I'm sorry, I didn't quite understand the question, Mo.
One of the guests, Dr. Salsan Abu Zaid, made a comment that he has been sensitive to sound, and that could be contributing factor. So I'm saying that, yes, it could be because migraine, people are sound sensitive. And secondly, that could be related to the ear and the boxing. I'm sure his head was hit quite significantly. That could have raises the question of some dehiscence within the temporal bone.
Yeah, I
Yes,
think that's a reasonable thing too.
Gary, if you allow me, did you perform hyperventilation tests when you performed the video nystagmoscopy?
I didn't do it at the time of the physical exam. Sorry.
Okay, because I in my experience there, I have many patients which could experience after a minor trauma vestibular paroxysmia, with or with no contact cross compression syndrome. That's why when I look and I saw that there are some impairment of the cranial nerves, the oculomotor and the right rectus also. I will think effectively that it might be also a problem on central origin, a neurological origin. It might be probably post-traumatic, but it's the the sixth cranial nerve palsy generally after a concussion, even there was a degree of intracranial pressure, had a good evolution after. If there is a mild trauma. So yes, I think that here it may be an intricate etiology for his dizziness and his symptoms at this time.
Yeah, point well taken. I think those are some great ideas. The only other couple things I would add is number one, there certainly is a possibility it may be unrelated to the trauma entirely, and it could just be coincidental. In which case we could be dealing, with someone who's got left-sided tinnitus, left-sided fullness, progressive disequilibrium could be a tumor, which is a possibility. The other is, as you mentioned, central issues. And then the last one I would throw out there would be delayed endolymphatic hydrops. Although he's not presenting with vestibular spells like hydrops, but with that fullness, pressure, hearing sensation, that would one of the things that would come in my mind with this. So I'm going to push on with the rest of the presentation. And let's see here. Okay, how do I get that up? Okay, so back to the slideshow. Oops. And so here is his audiogram. And as you can see, he's got essentially normal pure tone testing, normal speech audiometry, normal word recognition scores, other audiometric tests we did, normal impedance, normal ECOG, which doesn't completely exclude hydrops, but certainly makes it less likely. A normal ABR, which I would use as a proxy for the vestibular paroxysmia or something compressing the eighth nerve. So I think that would make that less likely and a tumor less likely. And his otoacoustic emissions were normal as well. This was his cervical vamp, and someone asked for cervical vamps, and this was his cervical vamps, and they were pretty symmetric. We got thresholds of 85 decibels, amplitudes of 144 on the right and 188 on the left, and that's pretty normal for our lab. Maybe a tiny bit on the hypersensitive side, but that's pretty normal looking CVEMs. OVEMPs were another story. Now, OVEMP, in our lab, we do both 500 hertz and 4,000 hertz. As you can see, he had no response for 4,000 hertz in either ear. But when we did the 500 hertz, he had a response of 81 microvolts on the right side. In our lab, we will look up to 60 to 80 as our cutoff for normal. So 81 is just on the other side of our normal range, but that may be normal. Left OVEMP, no, that's definitely abnormal. We got a response of 218 with a 46% asymmetry. So we definitely have asymmetric OVEMP with the left side being much more responsive. Next was the caloric testing, and there was a 25% weakness on the left side, which is a significant finding in our lab. So again, we're getting this theme of left, left, left. We got left-sided symptoms, left-sided abnormal OVEMP, left-sided caloric weakness. Here was the rotational chair testing. SHA results demonstrated reduced gains for essentially every frequency tested. The step rotation testing demonstrated reduced gains, particularly on the leftward rotations. Then with the higher frequency testing, we did active head rotation with vestibular auto-rotation testing and with VHIT. And for the horizontal VAT testing from 2 to 6 hertz, you can see all the gains are down. For the vertical testing, they're kind of skirting, they're a little lower in the lower frequencies, but skirting the lower edge of normal there with a 2.1% left asymmetry. Interesting, on the video head impulse testing, there was really only one canal that showed abnormalities, and that was the left posterior canal. VHIT had a gain of 0.7 with covert saccades. Other tests we did included video ocular counterroll testing. This demonstrated reduced counterroll for either side, less than 3.5 degrees, which, according to our lab, suggests that there was probably utricular dysfunction on one side that has been mostly compensated for, or possibly bilateral utricular dysfunction. Posturography was completely normal, including sensor organization test number 5, which is, as we know, the one where you are completely dependent on vestibular function to stay upright. We did platform pressure testing, and those of you not familiar with that, that is, we have the patient on computerized dynamic posturography condition number 5, and we put alternating positive and negative pressure in the ear, measuring the balance before and after pressure application, and essentially the right side demonstrated no change. The left side, however, caused him significant imbalance. Among the central vestibular tests, all were normal except for VOR suppression in the chair at 0.08 hertz, but it was a very borderline abnormality. And he had some breakdown in his pursuit at 0.4 hertz, but was normal in the lower frequencies. We did Tulios testing, and what we do on Tulios testing is we present of low frequency pulsing sound at 110 decibels and look for nystagmus and symptoms of vertigo or dizziness. And for our patient, it was abnormal on the left side. We did not see anything on the right side. We also did nasal and glottic valsalva, which was abnormal for both. And this actually produced nystagmus and the patient describing vertigo, which was interesting in that he never noticed that before in the history. When we actually got him to do the valsalva, it provoked vertigo, and which leads me to wonder if maybe he was just kind of practicing trigger avoidance, avoiding those kind of things that would provoke that. We did the fistula or Hennebert's test, and that was kind of equivocal. It was suspect in that it produced a slight upbeating nystagmus for either ear, but no associated symptoms. And then lastly, we did the tympanic membrane displacement analysis, which is our non-invasive way of looking at intracranial pressure, and that was normal. Although I will tell everyone the test is great because it's non-invasive, but it's not as accurate as doing something invasive, and we find it's about 80% accurate. So keep that in mind with this case. So that left me the diagnoses I had at this point was left uncompensated vestibular loss, third mobile window disorder, left and possibly right. I'm not nearly as impressed with the right side. The lateral rectus palsy, as we mentioned, and the history of BPPV that has been resolved for now. At this point, I'd like to open up the floor to discuss again anything more you'd like to say or refine your differential at this point, gentlemen.
Can we go back to the audio, because I think there is an interesting point to make on his video.
Yeah, there's the audio.
Sorry, audio. Yeah. If you look at the left ear, the low frequency actually is kind of semi-rising pattern. If you were to do the 125, it'd probably be down. And I think those patients, if you use the tuning fork on the elbow or the ankle, will probably lateralize. So this is just an observation. And I've seen that several times, Jerry. Beyond that, it was also interesting to note the Tullio was positive, but the Marchbank was negative. What are your thoughts about that?
You know, my thoughts are a couple things. One is it could just be, that he has normal intracranial pressure. Second, could be he's got fluctuating intracranial pressure. We're catching him at a time when it's normal. Or third, it just could be just not giving us the right results. Because one of the issues with the test is, and he's a perfect patient to use it on, but you need to have normal middle ear mechanics, normal acoustic reflex at 1,000 hertz, and you have to have some good connection intracranially to be able to get a result. Now, the way we check the intracranial, whether there's an intracranial connection, is we check them when they're upright and also when they're supine. And apparently he did have good connection because we saw the pressure go up. But at least on what we found on that day, it looked normal.
Right. His BPPV was left or right, or it's undetermined?
I don't know, because when we checked him, it was not there.
Yeah. I think there's something wrong with the left ear.
I would agree with you there.
Before we see what the images are going to show us.
Eugene, do you have some thoughts or want to narrow things down some?
I agree with you. There is a problem on the left ear, at least. But I would like to see the moderate. What did you order? An MRI or an TDM and scanner, petrosal bone?
So I'm a belt and suspenders guy. So I got both CT and MRI done, and Bradley loves this because I give him a lot of business to keep him busy. Just before we move on to that, I'll just mention someone asked about reflexes, eustachian tube dysfunction. There were normal tympanograms and normal acoustic reflexes for this patient. All right. So I'm going to now turn this over to Dr. Shore, who's going to read the imaging.
Hi guys. All right, so this is a grayscale inverted CT through the temporal bones, and it's an oblique coronal. It's a Stenver's view, and so what we're pointing out here is an absence of the partition between the tympanic segment of the facial nerve and the basal turn of the cochlea bilaterally. So he has a third window and bilateral cochlear facial nerve dehiscence. All right, Jerry, we'll do the next slide. So this is an axial T2 sequence through the posterior fossa. And he had a left retrocerebellar cystic mass that followed CSF on all the pulse sequences posterior to the left cerebellar hemisphere. There wasn't much in the way of mass effect. On the post-contrasted images, there was no enhancement. And, his cerebellar vermis was normal. He didn't have any fourth ventricular dilatation. It wasn't really a Dandy Walker kind of variant picture. But I suspected this was probably an arachnoid cyst without much mass effect. Okay, Jerry, we'll do the next one.
And I should point out, we finally did get the scans from 12 years earlier, and the cyst was there, and it was insignificantly different in size, maybe just a hair bigger than it was 12 years earlier.
Okay, so this is an MP RAGE sequence, and this is a contrast enhanced gradient echo sequence that is it's a 3D acquisition, and the reason we do that is it gives really good anatomic definition of the venous sinuses, and you can see filling defects in the venous sinuses really well, and you're able to see the caliber of the sinuses. And so he has an asymmetric tapered narrowing of the left transverse sinus as compared to the right in the vicinity of this retrocerebellar cyst. We'll do the next one. Next slide, Jerry. So this is, yeah, I got it. So this is another view of that sequence. And so these are parasagittal images on either side of the torcula showing that asymmetry of the transverse sinus. And you can see that the left transverse sinus is diminutive with this circumferential narrowing. The right transverse sinus is normal in caliber. And then we'll do the next image. And this is on the sagittal images on the left. You'll see that retrocerebellar cyst. There's some superior bowing of the tentorium. And then in the region of the pituitary gland, there is a concavity along the superior aspect of the pituitary, consistent with a partial empty sella. Normally, we'd like the pituitary to occupy about 2/3 of the volume of the sella. And so you can see this concavity along the superior margin of the sella. The image on the right is demonstrating these decreased volume of the lateral ventricles, almost like a slit-like appearance that we can see in increased intracranial pressure. Then we'll do, I think we have a slide of the orbits next. Yeah. So this is a T2 weighted sequence. So CSF is bright, coronal through the optic nerves, demonstrating dilatation of the optic nerve and optic nerve sheath bilaterally. He measured on the order of 7 to 8 millimeters. Above 5.5 millimeters is considered pathologic. And importantly, the CSF around the optic nerve, the distance between the optic nerve and the optic nerve sheath on him measured about 3 millimeters, even a little bit more than 3 millimeters. Above 2 millimeters is considered pathologic for increased intracranial hypertension. So that concludes the imaging portion.
And I have just a couple of, I think, educational slides I thought worthwhile going over, especially for those who are not familiar with cochlear facial dehiscence. It was originally described by Blake and colleagues in 2013, which is incidentally the same year our patient had his concussion. And it is describing, if you look in the upper left-hand corner, they did a nice little anatomic drawing showing the labyrinth and how where you see where the portion of the facial nerve, the labyrinthine segment comes over the cochlea, and that's the area we're talking about. And on the right-hand side is a histogram from Fang and colleagues where they looked at 1,000 temporal bones to see what is the incidence of cochlear facial dehiscence. And this is one of the ones where you're seeing the facial nerve effacing naked cochlea, so there's no bone between the cochlea and the facial nerve here. And they found that in 0.6% of the 1,000 temporal bones that they analyzed. I think one important point I want to make about this is that same temporal bone library, which was the Johns Hopkins Library, a number of years earlier, they looked for the incidence of superior semicircular canal dehiscence, and they found the incidence to be 0.5%. So cochlear facial dehiscence is actually slightly more common than superior canal dehiscence. Further, if you look in the bottom left-hand corner, they rated, what is the incidence of the thickness of each one of the temporal bones, what they call the CFPW, cochlear facial partition width. The average or mean was 0.23 millimeters. 35% of the patients had less than 0.1 millimeter bone thickness there. Now, just to give you a frame of reference, the average copy paper is about 0.1 millimeter. So what they're saying is here, 35% of temporal bones have less than the thickness of a sheet of copy paper between the facial nerve and the cochlea. So when we're looking at these on CAT scan, I dare say that for that group of patients, it's going to be hard to determine whether they actually have bone there or not. And that's where I think the testing becomes more important because, they may have bone there or not there, but if the testing is normal, it's probably not significant. If the testing is abnormal, it's probably significant. Most otologists are more familiar with cochlear facial dehiscence in the realm of cochlear implants. It is purported to be the most common cause for facial nerve stimulation in patients who've had cochlear implants. And as you can see on your right, here is a cochlear implant, and the electrodes are sitting right next to the facial nerve. As you can see how if you have a little electric discharge there, it's going to cause their face to twitch. And so what happens is the docs or the audiologists have to go in and turn off those electrodes. I even saw a case of one cochlear implant that was implanted into the cochlea, and then it actually went through the dehiscence into the facial canal, which could be problematic. Next, I'm just going to talk a little bit about the sixth nerve, or abducens nerve. It is the nerve that innervates the lateral rectus muscle. It is the most common cranial nerve palsy seen with increased intracranial pressure. And it's presumably because of its unique skull base anatomy. If you look at the area of the skull base where the petrous bone and the clivus meets, there's this yellow line, which is the petroclinoid ligament, and the abducens nerve goes through there, and that's where it converts from being intradural to extradural. And because of that pressure differential, supposedly that's why the nerve gets tweaked when the pressure goes up. Lastly, I'm just going to mention about arachnoid cysts. They are CSF collections. As Bradley mentioned, they look the same as the rest of the CSF. They're presumably from split arachnoid layers. They're usually incidental and asymptomatic. They're thought to be congenital, although I know there are cases that have been induced by trauma, and I know of at least one case induced by radiation therapy. Their expansion is purported to be due to either a one-way valve effect or possibly an osmotic gradient, and they cause symptoms strictly from their standpoint of their ability to cause mass effect. They don't invade into anything. So at the end of that, my diagnoses were cochlear facial dehiscence, left retrocerebellar arachnoid cyst, and possibly increased intracranial pressure. And so at this point, I'd like to open up the discussion, more broad-ranging. And number one, are there any other tests that you guys would like to do on this patient, or other diagnoses that I didn't have that you think is worthwhile pursuing? Comments, questions? guys.
Um,
Don't leave me hanging here.
you started this time, Eugene. Your turn this time to go.
Yes, case it's very challenging because and yes, I think that for the business within the tests you perform and the with the hyperpressure in the outer ear indicates that very probably this little third window abnormality it's responsible for the otologic and vestibular at least a part of symptoms. But now I think that the patient should, if you explain to the patient, if you can explain these problems, did he will be bothered in the point to accept a surgery for this type of peripetrosal third window abnormality, because the surgical options are very limited in this case. Or he would accept that he might be a problem on his left ear, and he will accept the symptoms and with no further treatment, or we can eventually propose an anti-membranous treatment. I would start with that, but I think that the surgery, for instance, is not an option, and when looking to the audition, which is normal. This is my point of view of this stage. I would like to see the evolution with the patient when stabilizes migraine problems, his headache, etc. And of course, I think that the using lens for the palsy could generate some postural problems. I think that postural control might be perturbed by using lens.
No.
Prisma, pardon, excuse me.
I would certainly agree with all of this, and I'm wondering if we can actually put him on a decent dose of Diamox and watch what's going on for a couple of weeks, 3 weeks, with good monitoring and documentation of his symptoms, particularly the vertigo and accompanying nystagmus, and see what happens. I don't think that the cerebellar cyst there is contributing factor, and I'm assuming also that the transverse sinus on the left side was also present,
Yes.
Jerry, in the initial MRI.
I think those are great comments, and I would, for the most part, agree with everything you guys have said. I think the basis for this guy's problems, he's got a unique set of anatomy that sort of predisposes him to having elevated pressure. And the concussion probably caused a little bit of increase in pressure that then progressed, and it kind of got into that vicious cycle. The higher the pressure, the more compression on the transverse sinuses, the higher the pressure went up, the less the venous drainage, and it progressed over time. So I would agree. I think the mainstay of treatment for him is going to be getting the pressure down. And I started him on acetazolamide.
Oh, good.
I have to admit, I was torn between initially doing a lumbar puncture to see what is his pressure. But a lot of folks aren't crazy about doing that to start. So I started him on acetazolamide, and my approach with acetazolamide is always start off really low, just because so many people find it intolerable, and I just slowly inch it up. So I don't have a lot of follow-up on him, but I do have a couple weeks, and he told me that pretty much after the first week, his vision cleared up. His diplopia went away,
Oh,
which to me is a positive sign that just taking a little bit of pressure off made a big difference for that abducens nerve. He said from the standpoint of his vestibular function, that's gotten better, a little tiny bit better every day. And so I spoke with him, I guess, after about 3 weeks of 250 milligrams of acetazolamide. So what I did was I bumped him up to 500 milligrams. And so I'm going to see how he does over the next few weeks. I agree. I think surgery is something I would reserve for after all the rest of this stuff is under control, if he still has problems. I had a patient not too dissimilar from this a while back, who someone went and did surgery for the cochlear facial dehiscence, and the patient was no better. And in fact, the pressure in their head felt worse. And, the patient got immediately better on acetazolamide, but developed kidney stones. And so I sent her to a neurosurgeon who did a ventricular peritoneal shunt, and that resolved all the issues and never had to do anything more for the patient. Is there any other imaging you guys would consider doing on a case like this? Or do you think we got everything we need?
I think we got everything we need.
I just would like to put one question, Gerard. How do you explain the deficit on the posterior semicircular canal and the presence of the upbeating nystagmus where you performed? Do you have an explanation for that?
I don't. I don't have an explanation for it. I wish I did. All I can say is, the Hennebert's test, it may have just been happenstance that he got a little bit. Maybe it was an alerting response. I don't know. That posterior canal V-hit looks pretty solid though, and I don't know if maybe because of the pressure he got some damage to his posterior canal. Now, keep in mind, when you're looking, as looking at V-hit, we're looking at, around 10 hertz. So we're looking at the very high end of the spectrum. Whereas when you look down at the lower end, his calorics and the rotational chair, there's obviously some dysfunction of the lateral canal. So, and as well as on the V-hit, there was not the V-hit, but the VAT, there was some vertical channel involvement. So I think there's kind of a global damage on the left side. It's just at the very high frequencies, it's only showing up on the posterior canal. That would be my take. Why it just showed up on the posterior canal V-hit, I really don't know.
I mean, the question, maybe I missed it. Has the posterior canal been documented on a video that we have seen? It could be
Yes.
it could be the horizontal canal.
The horizontal canals on the V-hit look fine. They look normal.
Yes,
It
exactly.
was only the posterior,
Right,
posterior
only the
semicircular
posterior.
canal on the left side was the
Right.
problem.
Yeah.
And may I have a suggestion? Eventually, if another MRI in 3 Tesla would be performed, it will be interesting to search after an eventual neuropathy on the kind of modification on the sixth cranial nerve and on the third cranial nerve on the right side. Would be interesting to see that there is not a primary neuropathy of the cranial nerves. They are very rare, but they may exist.
So maybe Bradley can chime in here. What will we see on a scan that would show some pathology beyond, like we saw with the optic nerve with CSF in there? Would we see kinking or something?
So of the abducens, you mean, or of the third cranial nerve?
Either or, huh?
Yeah. So
There-
basically,
Sorry.
Yeah, so I mean, yeah, I don't think, especially as it passes through cavernous sinus and Dorellis canal, we don't, we'd be looking for, secondary evidence of mass effect, either a mass or, maybe a posterior communicating artery, aneurysm. But to the actual visualization of the nerve itself is somewhat limited. What we all, there are times where Dorellis canal and Meckel's cave can change diameter based on increased intracranial pressure. Some have described it as an increased diameter, and some have described it as a decreased diameter. So I think those are pretty, not very reliable markers. So basically, we would be just looking for extrinsic contact from, either a mass or a vessel.
Interesting.
I think a
Thank you.
neuro-ophthalmology follow-up would be reasonable as well. And Jerry, and that's for the faculty and everybody. Why do you think he has been boxing for several years? Why now? Because of the deficits that we've looked at have been there. Why now? Is there any medical legal issues here?
No, there is none. No, he
Okay,
actually
good. So-
came to see me from outside the country, where I have, as far as I know, there's no litigation involved in it. I think the neuro-ophthalmology question is pertinent. From my understanding, there was no evidence of papilledema, and he'd been examined by multiple physicians for that, which is not that unusual in my experience with elevated intracranial pressure. Probably the minority have papilledema. And I didn't show this, but you could see on the, I don't know if it's on his MRI scan, but a lot of them, you can see the dilation of the optic nerve sheet, but no evidence of papilledema on the MRI scan in a number of these folks. My bigger question, though, is what's the prognosis for the abducens nerve when it's been tweaked and pressured for so long, and how good of a recovery can we get from that? Are there any ophthalmologists on that might give us some insight onto that?
Till then, if you allowed me, Gerard,
Yes.
I think that as for other type of third window abnormalities, if the interface, the bone, is very thin, but with a traumatic concussion, I think that there may be that could be occurred microfractures at the levels of the cochlear facial distance, which could lead to aggravation of the patient, namely with the otologic symptoms and vestibular. I think that he became symptomatic this year, but it's not. We cannot put a link between the otologic problems and the problems of the sixth cranial nerve and the third, of course.
Yeah, I think that's a great point. I'm kind of a believer in the straw that broke the camel's back, so to speak, when it comes to that concussion was probably just a little bit more he needed. Because, like you said, presumably for 5 years he's been getting hit in the head, and it was just the last one that took its toll. And whether it was from increased pressure or a direct fracture or what have you, I don't know. But we do see trauma as an inciting event in at least half of the patients with third mobile window disorders. And the thing that I find is interesting is that it's not always immediate. It's often delayed. It's actually usually delayed, like in this case. So this 2 or 3 month lag period is actually not that unusual. According to the Hopkins group put out a paper looking strictly at superior canal dehiscence. And in those, they found half of the patient's trauma was the inciting event that caused them to have symptoms. And of those, only 30% had immediate onset of symptoms. The other 70% had delayed onset. So 2 to 3 months is not unusual in my experience. And I guess, the way I've thought about it is, it's a lot of times there's so much going on after head trauma that they don't really think about it. And they don't know what's causing their problems. And a lot of times, like nose blowing and straining makes things worse. And it can be progressive. And it's not until they become more active that they start having trouble. I'm curious of your thoughts on that.
Yeah, I would definitely, the vertigo or the ear symptoms, shall we say, unless they are major ones, they usually come on later on. Jerry, would you, if you get asked, can I continue to play doctor? What would be your answer?
Only if you want to have more trouble.
No, yeah, I mean these, there's
Well, I will tell you,
a lot on the line here.
Yeah, this particular gentleman is not boxing anymore, but it's such a common scenario. Patients will ask you, "Can I continue to do this?" And of course, if you want to have more trouble, absolutely. So let me just, I had a whole bunch of other questions I put up here. Do we all pretty much agree the arachnoid cyst is kind of not really causing an issue here, other than maybe giving him some unique set of anatomy that may have predisposed him to elevated pressure? Is that the consensus we've got? So I would think I don't know if there's a neurosurgeon on here, but my opinion was if you went in and fenestrated this arachnoid cyst, you probably wouldn't get any long-term benefit unless it leads to lowering intracranial pressure, would be my thoughts. And the patient asked me several times about, I need to go get this removed. And I said, well, hold on. Let's kind of see how you respond to medical therapy first. Next, I know we have at least one or two vestibular therapists in the crowd there. Anybody want to take a shot at what they would do from a standpoint of vestibular rehab for this gentleman? Because he does have a left uncompensated vestibular loss, and you've got a pretty good list of all the vestibular deficits he has. I'm curious, is there any particular type of vestibular rehab that you think would be appropriate for this person? Abby, are you out there? Oh, Morgan. Hey, Morgan.
Good morning. Yeah, hi.
Morgan's out from Seattle, and she's an excellent physical therapist who does vestibular rehab. I'm curious to see what you think.
Yeah, what a very interesting case. And certainly if I saw this patient, I would certainly referral out. But given the left side weakness, history of migraine, I would definitely want to evaluate the individual's neck proprioception to see if there's any kind of compensation that we could get from that, and certainly lifestyle and if he never went through with surgery or anything in the future, kind of what Dr. Hamid said is just how is the patient going to tolerate symptoms with everyday life? So do a lot of habituation, and if we could get specifically that left posterior canal to give a little bit more function with the adaptation, VOR exercises, I'd be curious how far he would get without intervention. So.
Awesome. Thank you. Thank you. Any other thoughts or comments?
If he continues to have persistent left vestibular dysfunction, and objectively you can see that there is definitely decompensation, would you consider gentamicin perfusion in this person?
I would not, and part of it is I'm just very conservative in preserving vestibular function. I think if he did not compensate, I would probably assume the reason is because he still has fluctuating vestibular function. And if we got the pressure under control and his eye was back to normal, then I would consider doing round over window reinforcement, maybe even a sac decompression for this. I know he doesn't have high drops, but I think it helps reduce the pressure to the ear. And I think that would be the little range where I would consider surgical intervention in this fella, but only after he's been through a good range of medical therapy and vestibular rehab.
Yeah.
Eugene, yourself, would you consider something more aggressive like gentamicin or?
No, I would like only to follow the recurrence of vertigo and the type of vertigo. I would, frankly, I would like to see the dimensions of the internal auditory canal also. If the clinical picture would be spinning vertigo, which doesn't last 4 minutes or more than 5-10 minutes, I would think also, as I already told you, maybe there are some similar kind of spelling as vestibular paroxysmia or stereotypia. And in this case, the patient, because he has some antecedents of migraine, I will try even neuroprotections with the carbamazepine, oxcarbamazepine.
Excellent, excellent.
Yeah, I think that the medical treatment is definitely number one. But I again, that could be a little bit unusual if eventually he might need maybe just one gentamicin or one dexamethasone, depending on the clinical presentation. But I think he would do very well with controlling the migraine and the intracranial pressure.
Well, we're just at 11 o'clock, guys, and I am going to just remind everybody that we've got one more, or excuse me, I said our next conference is going to be May 2nd, and we're doing this the first Friday of every month. And the next case, Mohamed Hamid is going to do the presentation. It's going to be a case of recurrent BPPV with a tragic outcome. And I'm going to leave you guys with that cliffhanger there. And that would, I think, conclude our first case presentation. Unless there's any other comments, I think I'm going to end it here. Anything else?
Thank you very much, Jerry. This has been great.
Thank you, Jerry.
And we look forward to more of the first Friday of every month under your guidance. Thank you.
Awesome. And if anybody has questions beyond, I'm going to post this to YouTube and we'll compile those and maybe we can discuss those before the presentation next month. So thanks for everybody joining in. I've enjoyed it. I hope y'all have, and y'all have a good weekend. Take care.
You too.
Thank you. Thank you very much. Thank you very much all. Thank you.
Thank you.